All right, so we're live, Miss Amira. we did how to pronounce names before we got on here.
Yes.
Amira, so glad to have you here. You're such a talented author, writer, person in this DEI space that is, we're just thrilled to have you here. And of course, we are double thrilled because we're going to have you at our Seek workshop in Memphis in
Yes.
September. So that's going to be a special treat. So why don't you introduce yourself to our audience? I mean, I already put something in the preamble, but let them hear it from your own words.
Well, thank you so much, Sharon, for having me. It's an absolute joy and pleasure. I have fun every time I speak with you. I've just got this grin on my face because it's always a joy. But Amira Barger, as you mentioned, I am a practitioner of both diversity, equity, and inclusion, and healthcare communications. And I get to spend my days working with institutions across the health ecosystem, for-profit, nonprofit, government, you name it, to really think about shaping the employee experience, transforming their institutions, and thinking about the policies, the practices, and the behaviors within their organization that have a net impact on the patients, real people in community who need the products and the services and the thinking of these institutions to really thrive in life. And I got my start in this space because my parents once upon a time were ministers on the tiny island of Guam. And it was through that upbringing in community with people who were expressing a myriad of needs. And it really made it very clear for me that there's so much to this thing we call public health. All those non-medical factors of where people are born, how you're educated, the color of your skin, the way that you identify. These are things that impact how healthy you are because of the systems and the structures and the way that they treat us disparately depending on those dimensions of our diversity. And I'm excited to be here with you today in community and to chat about the wonderful things I get to do with the people who are on the front lines, our healthcare providers and physicians and nurses, you name it, who actually help those patients get the care that they so desperately need.
I'm so grateful for voices like you, and I'll tell you why. Because when we had on the pre-chat, maybe a week or so ago, I love that because we're not here to bash doctors, right?
Right.
We're here to bring education, to bring enlightenment.
Mhm.
That's what the Seek workshop is all about. We have, thank God for doctors, right?
Yes.
Amazing healthcare providers, amazing people in the space. But we do recognize that there is a disconnect at times, like you said, for lack of knowledge, right? And that's what the Seek workshop that I'm just looking forward for you to be at in Memphis. That's what it's all about. We have our first virtual Seek, so it's our first one on this Saturday. And it's just for that, to bring this kind of information, Amira, to the healthcare community,
Mhm.
differences and the systemic things and the misunderstandings that literally impacts outcome and care. And I was curious about something when I was when I was typing up, the introduction for you. I saw IED, and I'm like, "What is IED?" I gotta ask her, "What is IED?" And then I realized, oh, it's DEI. It turned out.
Yes. Yes.
Why do you do that? Why do you say
Mm.
IED instead of DEI?
That's a great question. Thank you for noticing that.
Mhm.
That says a lot about you that you noticed and picked up on it. I do that because so often the work of diversity, equity, inclusion focuses so much on that first letter in the acronym, the diversity, the representation piece. And I say often representation does not equate to results. It is important that we have diversity, which means the sum of all of us. That includes white people. But I start with inclusion because that's really what we're working towards in terms of providing people. It's not just about a collection of people. It's not just about a number, but it's really about addressing systems and structures that create situations in which true inclusion of those voices, those perspectives, and those lived experiences are not being included in the outputs, those products, those services, those experiences that we create for patients and for ourselves, our employees within the walls of institutions. That's really what we need to address. It's not just a collection of all of us, but it's really who's at the table, what does the table setting look like, who gets to decide, who gets to send the invitations, all of the components that really mean that not only are those people and their experiences there, but that those people and those experiences are taken into account. And I often say it this way, that it's one thing to be invited to the table, and it's another thing to hear that the table has been created with you in mind, meaning that your experience is thought of throughout the entirety of the process.
Interesting. I'm thinking I'm going to borrow that IED.
Yeah.
Because I don't want to be discounted or to be pushed aside because I'm coming in with DEI, because DEI unfortunately has been getting some negative rap, and it's a shame because it's so much more. It's not about color. It's about inclusivity, like you've always said. It's not about color.
Not only, race is a huge component of what we're talking about, because that's who's historically been excluded, right? That's one of the key dimensions of identity that we're trying to address. But to your point, there are other dimensions. How do you identify you're a member of the LGBTQ plus community? Are you a disabled person? So many aspects. Are you an immigrant? Those things all come into play.
That's for sure. Now, cultural humility. What's the difference between cultural humility and cultural competency? Is there a difference?
There is a difference, a big one. And to start off, I'll talk about definitions. It's part of the work that I do as a practitioner in both DEI and comms, is start with a baseline understanding. But generally, I truly believe that cultural humility is a more empowering framework that seeks to really celebrate communities, humanity, and individual humans, and understands that learning about others is this ongoing, lifelong effort, right? And setting a goal of mastering the totality of knowledge about a people or other peoples who differ from us is unrealistic. And it's more enduring to adopt a posture that is about inquisition, that is iterative, that is responsive to the needs of those around us and the ways that they are expressing them. And I learned this from being in the public health space, but also because I'm a communications professional. That's why I'm in a communications firm. And so often as communications professionals, whether in our writing or our talking, we repeat these common phrases, this word salad that we come across so often. Things like cross-cultural communications, multicultural communications, and community approaches. And one term, the one we're talking about today, cultural competency, it's one of those phrases that I've never really cared for. And it's defined as the ability to engage knowledgeably with people across cultures. And many of my comms peers or DEI peers, we are expressing a lot of the same sentiments, that it feels overcomplicated. It's not possible to be competent in all cultures, and it's not distinct enough to really be actionable. And cultural competence is a notion that healthcare professionals have very long deemed as an impossibility. And Dr. Daryl Wing Su, who actually coined the term, even said in subsequent interviews and writings that it is impossible, right, to understand the entirety of a group of people in our lifetime. And so I encourage people to embrace the concept of cultural humility. And that's a phrase also from the public health space. And it's a principle of equity from the toolkit that physicians and other frontline healthcare providers apply in the way that they engage in patient care and interactions. And cultural humility is really about, as I mentioned, an iterative process. It's responsive. It understands that using inquisition, being curious, are ways that we can better interact and understand the people around us. And there are different principles, right, that we can put in place to how we interact with others that will help us get closer to cultural humility. And I hold fast to those principles as a framework for how I move through the world and how I think about the world and people.
It's almost like when you say cultural humility, it's adapting a different posture.
Mm-hmm.
That cultural competence feels, just feels, like I said, just more overwhelming, bigger.
Very.
When I hear the word humility, I feel like what I'm being asked to do is to listen, right? To
Active
seek
listening.
seek to understand,
Yes.
listen, right? Actively listen, seek to understand, knowing that I don't know enough. And I maybe never know all of the issues of the other culture, but I'm going to approach it from a place of humility and teachability. Let's see, we have a question here from Sarah. In cancer, exclusion leads to poor health outcomes. It's not just about feeling left out, it's the result that people are dying because we don't understand diseases of treatment and impact. I love what you said about the priority of the order. I know she would love that too.
Thank you, Sarah.
We want to get our message across. We don't want it to be blocked because it's bigger than, like we said at the beginning, it's bigger than a color, right? It's about including all of these different people, being culturally humble, and because, as she said, the result of not understanding is poor health outcomes.
It is. It is. And, that's one of the reasons that I start with definitions so often and language, because language can be transformative. And that is the work of communications and DEI. So much of it is about how we frame things in order to transform the world. And in the space of public health and communications, we often talk about framing. And framing is about making choices about how ideas are presented. What are you going to emphasize? How are you going to explain it? What connections are made? What commitments are being invoked? And the choices that we make about how we frame ideas and our language have frame effects, right? They shape how people think about social problems, the world, solutions, and society. And framing is so important because what people will do is determined at any moment by how they imagine the world, and our framing choices determine how people will imagine the world. So as a communicator, I talk to people often in health communications that we have so much influence and power in how we frame and create frame effects with the language that we choose and our understanding. And to my point about definitions and words, so one of the reasons culture is so powerful is precisely because it's so present, and at the same time, it's very difficult to name or identify. And so understanding what we mean by culture, to Sarah's great point, is important because culture is the sum of shared values and beliefs, artifacts, meanings, symbols, attitudes, even aesthetic or styles of communications, all of which are created by a group of people that are learned and then passed on. So a shortened version would be behaviors and beliefs repeated. And within our organizations, particularly our health organizations, organizational culture is a person's behaviors replicated and become codified in our systems and our processes, our practices, and the way that we interact with patients and the ones that love them. So yes, we can impact culture by addressing systems and processes. That is central to the work of DEI, but we also need to address individual and interpersonal behavior changes to really help to change culture and move us closer towards equity and the kind of outcomes for patients that are needed. And that starts with understanding what culture is and the attitudes, the behaviors, and the biases that go into creating it.
Let's talk about where do you begin. So let's pretend I am an oncology office, right?
Yeah.
Hey, Amira, I want you to come in, and I want you to educate us on how we can do things differently. On IED, how come in and tell us how we can do things differently, because we are in this particular neighborhood and we have a mixed group and we don't think we're that effective. Where would you begin? Where would you begin with that office? What would you say?
With framing. One of the things that I do as a DEI practitioner, I do so many of these, whether it's a workshop, a training, individual coaching, and as opposed to giving prescriptive actions or tactics, what I like to do is to help give people framing, because framing is malleable. And one of the ways that I frame things for people is with these principles that I hold dear each and every day, that are informed by my upbringing and my former life in nonprofits, many of which most hospitals are nonprofit hospitals. But I provide principles because, you know, getting towards equity is about a way of thinking, a way of being. And so some principles that I hold to, that I will often deposit to people as a way to think and a way to be, there are 1, 2, 3, 4, 5 I want to talk about today. So the first one is language is transformative and it holds power, right? It has the potential to transform spaces in which we operate and the people that we encounter. And that includes the decisions that we make in framing information or ideas. The second one is systems must be transformed, right? To move through the world with that way of thinking and understanding that existing institutional systems that we have are historically and inherently built on inequity, particularly here in the US is the context that I'm speaking from. And our systems have to be changed and reimagined in order to help serve those patients and people that we care about. The third one is look to the margins and center those perspectives. Mari Matsuda at the University of Hawaii speaks about this a lot, and that's where I first learned of it. But look to the margins, meaning those people who are historically excluded, historically marginalized, historically underrepresented. They often have the best ideas and insights into what it means to be excluded and to shape inform us on the shape that justice can and should take and what repair can look like for them, for their communities. Go ahead.
There, because as you're saying that, I'm thinking, so what would that look like, for example, the doctor's office, would that look like a focus group with these people?
It could. Yes, it could look like a focus group in terms of the way we, if we're standing up a new initiative, a new program, when we think about the collection of our board of directors, the decision makers at the table, who are the voices there? Do they have the perspective of those who are at the margins? And if not, how do we get that? And how do we pull that into the room and into the process? It could be focus groups. It could be reimagining our nomination process for our board of directors. Mm-hmm. It can be thinking about the pool of the talent pipeline for who we're hiring, and taking a look at what are the competencies or the perspectives we don't yet have across the organization. So there are upstream and downstream tactics that we have to take in order to really get to more inclusion in shaping justice and repair.
Okay, I know I cut you off, but yes.
No, it's wonderful. Two more. So collective impact and solidarity, right? Change happens sustainably when our agency, right? Our choices about how we show up is collective and practice in solidarity, as opposed to saviorism, right? We're working with communities. We're working alongside people, not for them. And then the last one is critical reflection, right? Reflection is a vital practice in everything that we do. So examining the history of how we came to be as a health system or ecosystem, how our country came to be, because there's societal and cultural context to those things that help shape how our organizations move and operate in the world. So critical reflection to me looks like asking more questions and what you said early, active listening to those that are at the margins and including those ideas and insights into the actions that we take.
Beautiful. Go back to point number 4. I had something that popped in my head when you were saying your point number 4. I had
collective impact and solidarity.
Yeah. Can you repeat that one? Because I had a thought on that.
Yeah, that, we need to practice rooting out injustices collectively as communities, that we are co-designing, co-creating, and really cooperating with one another. It's not, just those in power swooping in to save, those who have been historically excluded. When I think about, hospital systems, how we choose community-based organizations and nonprofits that we partner with, within communities, and taking a local perspective on who are the leaders that understand the communities and are trusted partners that can help us think about solidarity and collective impact with, again, those who are most harmed by the systems that we're operating in.
I think when you said, the savior mentality, right? And we should be co-create. What that stirred in me when you were saying that was this idea that perhaps what we, there's a part two on the patient side and the community side. So how could we continue to empower the community that don't look for a savior? Don't look for a savior. Be part of it. Be your own advocate is what we say here at Total Health and Cancer Equity. Part of the things that we are trying to teach too is how can we educate the patients more, right? So that they're not looking for that savior. And you're right, it's two sides. It's two side approach. The doctor or his establishment, hey, looking at it like, hey, get input from this side too. Give more room, give more empowerment down here, so that you're not just the one answering and saving and because then they're coming from a different perspective. They don't necessarily know the other person's perspective. So I think that's all. If you guys want to hear more, you guys gotta come sign up for our Memphis.
Yes, live and in person. It's true. And the bit I'll say about that is that, no one needs to be saved, right? What people need, what communities need, is to be resourced with the supports and the environments that make space for the value that each of us as humans hold and bring. And so, to your point, how do we empower communities? Communities are empowered. What we need to do when we're in positions of power is to open the door wider, to bring another chair to the table for those voices and those insights to be included and to co-create with them. I think about the work I used to do in community clinics in the heart of Dallas, and it's widespread now, but community health navigators, right, is having voices and people that are trusted members of the community that look like the communities we're operating in, that can help to disseminate information, that can help to answer questions for those community members that are hard to reach and hard to count in many cases.
That statement that you made, we don't need to be saved, we need to be reached. That is so powerful. And I think if the conversation would shift that way, right?
Right.
When people hear DEI, there's this cloud, there's this anger, there is this resentment from different people. And this is the reason why I use the word, but I don't love it. Okay. That's why I was curious about the IED. I'm like, okay, what is that? And then I realized it was backwards. Because I feel like when I say DEI, the door is shut in my face, maybe, right? But it's re-educating everyone that no one's looking for saving, right? They're looking for resources, opportunity, be included, inclusion. And that's why I like inclusion being leading, because that's the whole point, inclusion. And all the 5 points that you brought out, it's where we begin, right? It is
where we begin.
Peter said, I think we had a few comments. Active listening, great point. What are some ways we can engage the community better in the setting of a cancer diagnosis? Not quite sure. What some ways we can engage the community better in the setting? We'll come back to that one.
Yeah.
Just how to answer that one, Amira. We'll come back to that one. Let me just see what Sarah said. When you encounter someone who rejects the principles of DEI, what do you think our role is? Is it convincing? As we move within the political realms, we are finding a spectrum of what people accept or reject about the impact of DEI in cancer. That's a good question, because this is what we're speaking about, right? When we get the resistance to the DEI, what is our role? What is our role as, nonprofit Cancer Equity, what you do, you're a communications person, what Total Health is doing, and what we're trying to do with our Seek workshop.
Yeah.
What is our role?
I think our very first role as individuals is to have awareness and understanding of what might be driving that, right? So that we can ask powerful questions, so that we can move powerfully to, in proximity and in relationship with people, help to shift behaviors and mindsets. So what I mean by that is not everyone can be moved.
Okay.
Not everyone can come to understanding. And that's important to understand and start with. Many can, but not everyone can. So focusing our energies on those whose mental models can be moved. So I try to understand mental models that shape people's understanding, particularly we're talking about health disparities, and they're worth understanding specifically because mental models can be changed, right, with new inputs and information. And so when I encounter someone who is uninterested in DI, I start with asking questions. Inquisition in the work of IED is a very powerful strategy. I'll often quip with, say more, right?
Okay.
And get them to explain what they mean. And I find that when you're in relationship with people, that's when you most powerfully help to change a person's mental model and reshape the way that they see the world, with that idea of framing effects, which people in health and public health will understand. But being in relationship, so when you encounter people who are not interested, who is closest to them, who's in closest proximity and relationship to them, to have a conversation, to ask some questions, and to talk about what we mean when we say IED, and the fact that no one goes unscathed where inequities exist. DEI is often something that people relegate just to Black and brown people. It's just for you all over there. But the waters that we swim in, as we talk about as DEI practitioners, white supremacy is the water. Everyone is impacted negatively by the existence of white supremacy. And so whether you are Black or Latin or AAPI or white, you should care about the inequities that exist, because there's a net impact to your ability to thrive as well when inequities exist for anyone. And in the public health space, we talk a lot about the curb cut effect as an example. So the curb cut is literally cuts in the curbs of sidewalks and streets that was originally fashioned for those with wheelchairs. But what we found when we put the curb cuts in is that it benefited those with walking sticks, those with strollers, those on bikes, those on skateboards, that there was a net positive impact for the entirety of a community with one change that answered the call for the needs of those in wheelchairs. And the same is true of DEI, is whether it's the Black community calling out, whether it's the Latinx community calling out, the AAPI community calling out, LGBTQ plus, disabled, you name it, where there are inequities that community experiences, solving for those equities, those at the margins who have been excluded, it has a net impact. And it's sort of that idea that all ships rise with the tide. Everyone will benefit positively if we address those inequities.
Well, Amira, we could stay here all day, but
we could.
Unfortunately, I'm going to have to let it go from here. But, as I said at the top of the show, Amira will be our Memphis speaker, one of our Memphis DEI speaker in September. And I just convinced her to be one of my guest bloggers on our Cancer Equity blog. So
done deal.
We'll hear more from her, but wonderful. I want to leave you with this. Sarah said she's manifesting that she'll be front row at your TED Talk. Okay?
I received that, Sarah.
And Franklin was on our team as well, says great podcast. Amira, you were a fountain of information, blessing. Like you said, we could talk all day, but I definitely would probably plan to be in Memphis just to hear you talk live. And so we just want to thank you again for coming on here, educating us, informing us. And we look forward to really working with you and certainly reading your blogs and just being in your circle. We could learn a lot. And so we just thank you so much. And so for folks, our wonderful, wonderful, faithful watchers, thank you so much. If your team replay, ask your questions. Amira will be checking the comments. So until next time, Awesome. Have a wonderful rest of the week, and we will see you back on Tea Talk on Monday. Take care.
Thank you.